So our first topic is going to be Pemphigus vulgaris. This is an autoimmune vesiculobullous disease process in which your body actually produces antibodies against desmosomes. Now, that's probably a buzzword that you remember from boards. What are desmosomes? These are the proteins that are actually responsible for holding the epithelial cells to one another, all right? And when you develop antibodies to those specific proteins, those epithelial cells will fall apart, and these people will eventually develop blisters that rupture, and this is a disease, again, that is mucocutaneous, meaning it can affect the mucosa and the skin. Interestingly enough, in most cases of pemphigus, a third of these patients are going to present with oral lesions prior to ever having any cutaneous manifestations. The difference between this disease and other vesiculobullous diseases is that inevitably these patients will go on to have skin involvement, all right? Population that we're typically going to see more frequently, we're going to see this in females, and they're going to be more often middle-aged females. So when we're talking about Pemphigus vulgaris, what do we typically expect to see clinically? Usually you're going to see irregular erosions, areas of erythema, and desquamation of tissue. Desquamation is whenever we actually put a little bit of pressure on the tissue and that tissue literally sloughs off, leaving or revealing the underlying raw connective tissue. And these cases, you will have a positive Nikolsky sign. A Nikolsky sign is the ability to induce a blister in an area of clinically non-lesional tissue. So an area that may be adjacent to an ulceration or an area of more marked redness. If you put a little bit of pressure in that area, you can actually induce a blister and cause that tissue to completely desquamate. Where does this affect the oral mucosa? Well, all the mucosal sites can be affected. Frequently, it's going to be the palatal mucosa, hard and soft palate, the gingival tissues, labial buccal mucosa, tongue. But again, any site can be affected within the oral cavity or oropharynx. Nearly 50% of these patients will have oral lesions prior to skin involvement, but inevitably this is a disease, like I mentioned before, that will progress to have cutaneous involvement. So I'm gonna go through a couple of clinical examples, that way we can see what this looks like in your day-to-day practice. Patients aren't gonna come in and say, hey, I have pemphigus. It's our job to figure this out and get patients on the right track for management. So this is a patient, and you can kind of see the gingival margins are very erythematous, and it looks like the gingival tissue is just falling off, and that's exactly what's going on. This is true desquamation of the tissue, almost like the tissue is actually in a process of degloving or completely separating from the underlying connective tissue. There's a few areas there in the vestibule. There's an area of ulceration, and then you can see this piled up fragment of white tissue, which is actually all the tissue that is peeled off within a region. When you look inside their mouth, you're going to see these kind of ragged areas of erythema or ulceration, and you have to be very careful. And I always typically like to ask, are there any really sore spots in your mouth right now? I've seen it one too many times where you stick a tongue blade or a mirror into the patient's mouth, and you go to remove that, and the entire mucosal tissue is going to come along with it. So it's going to make it remarkably more painful for that patient. This is a patient that we saw in my practice, a young male, and if you look in his mouth, he's been complaining of, just discomfort, not completely aware of what's going on. And you look in his mouth, there's these areas of ulceration in his buccal mucosa, but you also see these kind of ragged crateriform type areas of erythema, and those are truly areas where the tissue is desquamating from the mucosa. If you look on the left side of his oral cavity or oral mucosa, you can see the gingival tissues. There's areas of remarkable redness, and these are areas where the tissue actually has sloughed off and has left the underlying bleeding surface. And then on his soft palate, we have those kind of crateriform or ragged erosions or ulcerations, which is usually a more common sign that we see in pemphigus. This has been a good example of some of the clinical findings you're going to see. Remember, kind of ragged, irregular erosions, areas of ulceration, and desquamation. Those are going to be the really common findings in pemphigus patients. Some patients may present with cutaneous manifestations that may just kind of, the patients may be writing off as sore spots. Alternatively, they could know that they've had some blisters on their skin as well. Let's talk a little bit about histology. I am a pathologist, so I'm going to show you and burden you with this stuff, but it really drives home the point of what's going on at the clinical level. So on the left side of the screen, we have a low power view of the epithelium. And remember, the desmosomes are the proteins that hold each one of these cells together. And when you have inflammation that attacks these proteins, that tissue is going to fall apart. In this fragment, we don't have the underlying connective tissue because this portion of the tissue has completely separated from the underlying connective tissue. On the right side, you can actually see the epithelial cells are becoming individually rounded. And they're rounded because the proteins that attach them to each other have been completely destroyed because of inflammation. Usually when we actually get a diagnosis of this, patients will also have a biopsy submitted for direct immunofluorescence. And direct immunofluorescence allows us as a pathologist the ability to actually visualize where these proteins are deposited. And a great example of that is this finding here. Under histologic evaluation with an immunofluorescent microscope, you'll see the areas that are neon green, and that kind of what we refer to as this chicken wire pattern is very characteristic of Pemphigus vulgaris, as well as other categories or subtypes of pemphigus. And those neon areas truly represent the antibodies that are deposited and fluoresce under this microscope. So how do we treat patients like this? Well, treatment inevitably, you have to consider this a mucocutaneous or systemic disease, all right? It's not really gonna affect the organs, but any mucosal or cutaneous site can be affected, and therefore it is gonna be a coordinated team approach to management. Typically, patients will get systemic corticosteroids, but also immunosuppressants are a big part of the protocol for managing these patients based on the extent of clinical disease. So Cellcept or mycophenolate, azathioprine, these medications have been used. And again, rituximab is a medication that is used at a different dosage compared to the traditional chemotherapeutic doses to actually specifically target the inflammatory cells that are producing antibodies. And this is one that has become more and more commonplace in management of patients with mucocutaneous pemphigus. For oral mucosal treatment, I often work, as well as other oral medicine specialists do, in conjunction with a dermatologist or a treating physician to manage the patient's oral disease. Oftentimes, a moniker we learn in training is that with Pemphigus vulgaris, as I mentioned before, it's the first to show in the mouth, but usually is the last to go. And the reason that is because inevitably the oral mucosa environment has a tendency to already have a degree of background inflammation, which makes autoimmune and inflammatory conditions harder to manage because of that existing inflammation. With oral involvement of pemphigus, typically we can treat with topical corticosteroids or additional medications that can produce an immunosuppressive or immunomodulatory sort of profile. We do have to be very cautious when we're using corticosteroids in regards to the amount of mucosal absorption that these patients do get. Usually this is marginal, but long-term corticosteroid use or in patients that are also being supplemented with systemic steroids or other medications that are corticosteroids or within that category can start to get adrenal suppression. So this is something that you do have to be aware of. You want to make sure that you are not over-treating this patient with corticosteroids to shut off their own production of cortisol. Proper oral hygiene is a must for these patients. Any patient, and I'm going to kind of repeat this mantra throughout the lecture or throughout our journey, that any patient with an inflammatory disease process affecting the oral cavity, whether it's autoimmune or immune related, we have to increase their hygiene visits. That means we're not doing the biannual every 6-month visits. We're going to do these visits 3 to 4 times a year. We're going to make some modifications for these visits. I typically recommend staying away from ultrasonics, so just hand scaling until their gingival tissues are at a state where we have more intact tissue and the tissue has maintained a better level of integrity, right? The other thing I typically recommend that I've started to do over the last decade or so is we stay away from any polishing or the use of polishing paste. If you think about it, when we're doing this, again, it's great for getting rid of extrinsic stain. Patients love it because their teeth feel so clean, but the pumice-based products that we're using or any other product or alternative that you may be using, inevitably a portion of that will get embedded into the gingival tissues, which can be a nidus for further inflammation for that patient. Making those sort of small changes, increasing their visits to 3 to 4 times a year, abstaining from the use of ultrasonics and polishing paste will make a remarkable difference in regards to how better we can manage this patient's disease. So again, to kind of recap what Pemphigus vulgaris is, it's an autoimmune vesiculobullous disease in which your body is producing antibodies to the proteins that hold your epithelial cells together. The thing that's clinically important with these patients, they're going to manifest with areas of desquamation, ulceration, these ragged erosions and ulcerations or areas of erythema, And again, when you push on the tissue, it's going to have a tendency to just peel. And that could be in an area that's perilesional or in an area that doesn't even look like it's lesionally involved. Management for patients like this is going to be a coordinated systemic approach, whether it's through systemic immunosuppressants or immunomodulatory medications. And that could be something that is truly infusion-based, like rituximab, as well as management in the dental practice in regards to basic things like increasing your hygiene visits and making some modifications in regards to the way we provide your dental hygiene visit for these patients. That includes making sure that we stay away from ultrasonics until the tissue comes back to a relatively stable integrity, as well as abstaining from any polishing and polishing paste.
Thanks for watching. Strengthen your dental team skills even further by heading to the next video. See you there.